Hello, good afternoon and good evening, everyone. Welcome to the third webinar of Anesthesiology webinar series organized by Baxter this evening. I'm the medical affairs head of Baxter for Middle East and Africa. My name is Anıl Höbek. I will be moderating the webinar this evening. And today we have a very distinguished speaker from Düsseldorf, Germany, Professor Dr. Peter Kienbaum. Professor Dr. Kienbaum is professor of anesthesiology and he is the vice chairman of the anesthesiology department of the Heinrich Heine University and medical faculty in Düsseldorf, Germany. Dr. Kimbaum has more than 80 research publications in international journals with over 1,500 citations, and he has multiple research awards on anesthesiology as well. And today, Professor Kimbaum will be talking about inhaled anesthesia in clinical practice, particularly focusing on clinical advantages of desflurane-based anesthesia. And welcome, Professor Kimbaum. And before starting the webinar, I would like to make a couple of reminders for our audiences. If you would like to enlarge the view in your screen, you can just click the small square button on the screen you are just seeing right now on the right hand side, right lower part of the video that you are seeing right now. So you can see the presentations and the slides much larger. And also, we would like you to send your questions to Professor Kimbaum through the chat function on your screen on the right-hand side, so that Dr. Kimbaum can address those questions at the end of the presentation. Welcome to this meeting again, and it's my pleasure to hand it over to Dr. Kimbaum for his presentation. Please, Professor Kimbaum.
Good evening, ladies and gentlemen, dear colleagues. First, I would like to thank you, Anil, for the invitation and for your kind introduction. And to begin with, I'd like to let you know that I've been working with inhaled anesthetics for almost 30 years. And in the 90s, we started with enflurane, used isoflurane, and there were many years with sevoflurane, and now I have been working almost exclusively for more than 10 years with desflurane. Moreover, we did some research in my department with the anesthetic xenon, and I'm very, very happy to share my experiences with inhaled anesthetics with you this evening. To begin with, I would like to introduce you to the agenda that I chose for this lecture. I would like to start to talk about pharmacokinetics and recovery from anesthesia. Airways and sympathetic activation is always a concern of anesthesiologists. And then I keep on going with organ protection, post-operative brain failure, and will finish with a couple of case studies. And I would like to encourage you to put your questions and remarks in the chat function that we can address after I have finished the lecturing. To start, I would like to ask a question. What is the characteristics of an ideal anesthetic? And when I talk about this topic to my students, they most of the times tell me they are interested in a rapid and precise awakening from anesthesia, a lack of metabolism of anesthetic drugs. They should be free of unwanted side effects. And at the end, we need an optimal recovery from anesthesia and surgery. And to understand more about ideal anesthetics, we have to discuss some basic pharmacokinetic data. And in the next slide shows you the context-sensitive half-life of propofol. That means the time which needs to get a 50% decrease in concentration depending on the duration of infusion of propofol. And this data shows you that the context-sensitive half-life of propofol increases slightly with duration of application. However, To my impression, most important information is that there's a great variability between individuals. So many patients wake up very fast after discontinuation of its administration, where there's always a few that took a very long time, and you are concerned why patients don't wake up at the appropriate time. And this is a problem that occurs with all intravenous hypnotics. On the other hand, we have the alternative to use inhaled anesthetics. And basically, at the moment, we are using isoflurane, desflurane, and sevoflurane. And these anesthetics differ between, they have a difference in their solubility in blood, brain, muscle, and fat. And the higher the solubility, the slower the pharmacokinetics. And the isoflurane has the highest solubility, and the desflurane has the lowest solubility in blood, and the sevo is in between. Please note that the solubility of sevoflurane in fat is 3 times higher compared to that of desflurane. This solubility is related to the potency of the drugs, and I show you the MAC values for sevoflurane and desflurane depending on the age of the patient. And from sevoflurane, 1 MAC in the newborn is around 2.2%, decreasing to a little bit more than 1% in the elderly patients. Correspondingly, for the desflurane, the MAC value is something around 8% in the newborn, going down to approximately 4% in the elderly patients. And most important when talking about recovery again, it's the context-sensitive half-life. And for inhaled anesthetics, there's something like a decrement time that can be calculated. And these authors chose the 90% decrement time depending on the duration of isoflurane, sevoflurane, and desflurane. Why did they choose 90%? 90% is approximately the amount of anesthetics need to be eliminated until the patient can leave the post-anesthesia care unit. And this diagram shows you that when giving isoflurane, it takes like half an hour, 40 minutes until the 90% decrement time increases to more than 60 minutes. The sevoflurane is very good in the beginning, but increases its decrement time almost to the value of the isoflurane. And you can clearly tell the difference when you have been using both anesthetics. Compared to isoflurane and sevoflurane, desflurane does not increase its decrement time depending on the duration of administration. That means, irrespective of the duration of anesthesia, patient should wake up very fast. And we can have a look whether these experimental data reveal into clinical advantages. And in this diagram, I show you the time to extubation for patients receiving desflurane, isoflurane, and propofol anesthesia. And I calculated Gaussian bell-shaped curves that indicates the highest probability at 5.6 minutes when patients receive desflurane, and around 12 or 13 minutes when they were receiving isoflurane or propofol. The major information in this slide is also that there's a great variability with the isoflurane, similar to propofol. You just remember the data on the context-sensitive half-life of propofol I showed you before, and a very precise awakening when patients received desflurane. So this is a very important information. It's not only the duration between discontinuation of its administration until patients can be extubated, but it's also the precision that it's important line of argumentation in favor of using desflurane. However, I'm a little bit unfair at that point because these data were gathered in patients scheduled for bariatric surgery, and of course, in bariatric surgical patients, differences in pharmacokinetics depending on fat solubility um, are really big and more pronounced compared to normal patients. However, in the next slide, I show you data um, derived from young ladies for shorter gynecology surgery. And here you see the same thing, that the propofol patients take longer to wake up until then patients received desflurane, and the SIBO is somewhat in between, but almost as good as the patients who received desflurane. The next thing is that we must ask the question whether these differences in awakening times gives you any other clinical advantage. And to answer this question, Dr. McKay gave patients 20 milliliters of water to swallow after they were extubated. And this was not to give them something to drink, just to relax, but this was a test for airway reflexes. And when patients were starting to cough, she knew that airway reflexes had not been fully reestablished. And this is the data of her study. And when you take patients who received sevoflurane-based anesthesia, it took almost 20 minutes until most of the patients were able to swallow these 20 milliliters of water properly. In contrast, when patients received a desflurane-based anesthesia, um, each patient was able to swallow right away after they had been extubated. So it's not only a measure of time to extubation, but it gives you an additional safety for our patients. And when looking at a meta-analysis performed by Ulik, that was published in Anesthesiology in 2016, he could identify that patients who received inhaled anesthetics recovered faster. And in this forest plot, he shows that they were less prone to have post-operative respiratory complications compared to those patients who received a TIVA. So volatile anesthetics gives you less post-operative respiratory complications. So this is a safety reason to use modern inhaled anesthetics. And when I summarize the key messages of this pharmacokinetic part, I try to show you that the solubility of desflurane is less compared to SIVO. That gives you the other way around, MAC values, highest for DES and lowest for ISO. The extent of metabolism, I didn't show you that data, is that desflurane there's no metabolism at all, and SIVO is metabolized with around 5%, giving you compound A and fluoride and so on. So when summarizing this, we have a rapid and precise elimination of desflurane by the lungs, and these pharmacokinetics of desflurane translate into rapid, precise, and safe awakening from general anesthesia, irrespective of body weight and duration of anesthesia. So there's some reason based on pharmacokinetic data to use desflurane for your patients. Some doctors are concerned with airway reflexes and sympathetic activation after desflurane. And we have to talk about this issue as well. And to begin with, I show you a study where subjects were breathing 2 MAC of sevoflurane, isoflurane, and desflurane. And They recorded the breathing over several minutes, and these data shows you that when patients received sevoflurane, all patients kept on breathing all the time, while patients who received desflurane stopped breathing in approximately half of the subjects. Isoflurane was somewhat in between. So this data shows a certain airway pungency so that sevoflurane is recommended for inhaled induction. And this wouldn't work properly with the desflurane because half of the patients stop breathing within the first minute. What happens to the sympathetic nervous system? And a friend of mine, Tom Ebert, recorded muscle sympathetic activity in the peroneal nerve, measured blood pressure and heart rate by ECG, and he applied a high concentration of desflurane to the upper airways. And after a few heart actions, he saw a massive sympathetic activation that gives you an increase in blood pressure and an increase in heart rate. And this is not a central effect because it occurs very rapidly after the desflurane is mechanism. And he identified that this was based on pain receptors similar to laryngoscopy without adequate anesthesia, and then you receive a sympathetic activation and blood pressure increase. And if you use reasonable concentrations of desflurane, such as a 4% inspiratory concentration with 6 liters of fresh gas flow to introduce anesthesia, these sympathetic activations does not occur. And the product of inspiratory concentration of 4 and fresh gas flow of 6 brings me to the rule of 24. That means that 4 times 6 is the upper limit of higher concentration. So you should not use fresh gas flow 18 and vaporizer 18, but you should keep these numbers below, giving you a product of 24. So this is the rule of 24. We can talk about that later. And with respect to airway irritation, Anna Stefanovic looked at patients with laryngeal mask airways, so they could experience laryngospasm and coughing during anesthesia. And she did a systematic review, and she found that when comparing desflurane-based anesthesia to propofol and sevo, and also when comparing to sevo alone, there was no difference in laryngospasm in these patients when they were using a laryngeal mask airway. However, as you can see, these studies had very low numbers of patients, so that she decided to run a prospective trial with more than 300 patients, and patients received propofol anesthesia, sevoflurane-based anesthesia, and desflurane-based anesthesia. They had a laryngeal mask airway, and she was looking at laryngospasms and coughing, and these are the results. With respect to intraoperative coughing and laryngospasm, there was no difference between patients receiving desflurane, sevoflurane, and propofol. And also with respect to coughing at emergence and laryngospasm at emergence, there was no difference between groups, indicating that the airway pungency of desflurane is a more or less theoretical construct where there is no clinical situation corresponding to this idea. So when I summarize these data, of course, as you know, sevo is the anesthetic of choice for inhaled induction. Airway irritation of desflurane and sympathetic activation occurs only with rapidly increasing and high inspiratory concentrations of desflurane. And when opioids and the rule of 24 are used, it is almost without clinical relevance. In the next chapter, I'd like to talk about a very interesting phenomenon that were discovered almost 40 years ago. And I would give you some information on organ protection. And the first studies were run in dogs, where they did some cardiac experiments looking at ischemia and myocardial infarction. And the study of Murray and colleagues found out that in experimental infarction with an infarct size of approximately 30% of the area at risk, a limited ischemia prior to the longer ischemic period gives you an organ protection. And the results of the studies was that compared to control, when you had 4 limited episodes of an ischemia prior to the infarction, the myocardial area at risk and the necrosis is decreased to a maximum extent. So there's beneficial effects of a ischemic preconditioning in this animal model. And later on, they could show that it's not only at the vessel that is preconditioned, but also you can observe that when you do the preconditioning on the circumflex ramus and you do the ischemia on the left anterior descendant, you have a similar effect of myocardial protection, and even more when you do the ischemia at a limb of the animal, you can transfer this beneficial effect of limb ischemia to the myocardium. And this was the time where doctors thought about translating this observation into clinical practice, because of course you could not do myocardial ischemia prior to myocardial infarction, but of course you can do limb ischemia prior to a cardiac surgical procedure, for example. And Matthias Thielmer was the first to publish clinical data in the Lancet, and he could demonstrate this ischemic preconditioning or remote ischemic preconditioning had beneficial effects on troponin release of the heart during CABG and after CABG surgery. And we tried to confirm these data and participated in a large multi-center trial that was published in the New England Journal a few years ago. And Tanya Meyer-Treshan and I contributed several patients, and altogether this was more than 500 patients to each group, standard treatment versus remote ischemic preconditioning. And we were very thrilled at that moment to be able to hopefully show beneficial effects. But when looking at the results, we got these data. There was no difference in event-free survival. That was the primary target value between patients in the RIP-C group and patients in the sham RIP-C group. And at the same time, Derek Hausenloy performed a similar trial in the UK called ERICA trial, and he published his data in the same issue of the journal, and he received similar results. There was no difference between remote ischemic preconditioning and control in these cardiac surgical patients. And of course, we asked the questions, how come that these impressive effects in lab animals could not be translated into the clinical practice? And Ragnar Huhn of my group, he did some experiments in rats doing remote ischemic preconditioning during baseline pentobarbital, sevoflurane, and propofol anesthesia. And I show you the results of this study. The beneficial effects of remote ischemic preconditioning that could be identified during barbiturate anesthesia, during sevoflurane-based anesthesia, were eliminated during propofol anesthesia. So propofol somehow interferes with organ protection in humans and in animal models. And this brings up to the point that Judy Kirsten found out in the 90s that similar to ischemic preconditioning, animals could be preconditioned by inhaled anesthetics. And at this, the era of organ protection by inhaled anesthetics was born. And she could clearly identify again in dogs that isoflurane, in this case, gives you a major organ protection in experimental myocardial infarction compared to control animals. And many clinical studies were run, and one of the latest systemic reviews by Ulik identified that patients receiving inhaled anesthetics had a lower mortality in cardiac surgery compared to patients that received intravenous anesthetics. So in this systematic review, the beneficial organ protective effects of inhaled anesthetics were confirmed. Afterwards, Giovanni Landoni, first author Ligvantsev, ran a study with almost 1,000 patients showing organ protective effects of sevoflurane-based anesthesia with respect to decreased troponin release and decreased pro-BNP, decreased hospital stay, and better survival in cardiac surgical patients. And then he came up with a large trial 2 years ago, multi-center, more than 4,000 patients included, and at the end, and they were looking at organ protection again in cardiac surgical patients, and the primary endpoint was survival, and they did not find a difference between inhaled anesthetics and intravenous anesthetics. And what is the reason for that? We were very astonished because of the very optimistic and positive data before. Now Giovanni came up with this study. And when looking at the supplementary material, you find out that half of the patients in the inhaled anesthetic groups received propofol, and 15% in the TIVA group did not receive propofol. So when just remembering the data that propofol inhibits organ protection, this might be a reason for why he could not confirm this positive data in his study. However, in another section of the supplementary material, there was a comparison between desflurane, isoflurane, and sevoflurane, and this comparison identified that patients were better off with a lower 1-year mortality when they received desflurane anesthesia. So again, there seems to be a benefit with inhaled anesthetics with the most favorable pharmacokinetics. And the latest study with respect to organ protection was just published by my friend Matthias Eickermann from Boston, and he looked at 15 years of anesthesia at Beth Israel and Massachusetts General Hospital in Boston, and he collected more than 400,000 anesthesias. And in this study, he was looking at the brain and looking at patients with ischemic stroke. And in this patient group, they had 2,000 strokes out of 300,000 patients that were included. And when trying to characterize the patients, they found out that patients with higher doses of inhaled anesthetics had a lower risk of having a stroke compared to low dose volatile anesthetics. And this was irrespective of the risk profile. So the groups were balanced. And in the exploratory analysis, I found the passage that in comparison to TIVA, patients undergoing volatile anesthesia had significant lower odds of experiencing the primary outcome of postoperative stroke. So, again, in a large data set, it could be proven that inhaled anesthetics exert organ protective effects also in the clinical settings of our patients. So, when I summarized the data, we found out that ischemic preconditioning and pharmacological preconditioning induce an impressive organ protection in animal models. And organ protection by remote ischemic preconditioning was observed only in animal models so far. Organ protection by inhaled anesthetics are considered to be proven in cardiac surgical patients. We know that propofol blocks these beneficial effects, and ongoing research tries to resolve these blockades. And now, with the most recent data of analysis of large databases, these analysis suggests that potent organ protection by inhaled anesthetics in non-cardiac surgery patients as well. Just remember the data on postoperative stroke. Another issue after anesthesia is postoperative brain failure. And every once in a while, patients show up and talk to us that there must have been something wrong with their anesthesia because they were not feeling well and they were just having bad dreams and other things and could not think the way they did before. And the surgeon told them, okay, that's probably a problem of your anesthesia and you should talk to your anesthesiologist. And every once in a while in this situation, I quote this study by Ellert that was run in vascular surgery patients, and they had surgery at the lower extremity. And Ellert had three groups: one with general anesthesia, one with regional anesthesia, and one with local anesthesia. And his primary endpoint was the incidence of postoperative delirium. And he showed that patients, irrespective of anesthetic technique, like general anesthesia, regional anesthesia, or local anesthesia, all of them experienced an incidence of postoperative delirium around 20%. Accordingly, he summarizes that postoperative delirium is not caused by anesthesia, but there must be different issues or surgical problems that gives you a postoperative brain function problem like delirium. However, we know this is not true because in the US you don't receive regional anesthesia alone or local anesthesia alone. All of these patients, they do have a propofol infusion pump. They are sleeping, and to my impression, this is called room air anesthesia without endotracheal intubation, and this is anesthesia with endotracheal intubation, but all patients do have general anesthesia, and therefore the incidence of delirium, to my impression, is explained not to be different. However, Frederick Siever had a look at patients with proximal femoral neck fractures, and he used spinal anesthesia with deep sedation and lower sedation. He used neuromonitoring like BIS monitoring and targeted the one group with deep sedation to a BIS of 40, and with less sedation with a BIS of around 80 or greater 80, and he found out that deep sedation doubles the incidence of postoperative delirium. And this was one of the first studies that identified anesthesia to be a risk factor for postoperative delirium. And when you use neuromonitoring, it is important to recognize that the consumption of inhaled anesthetic is decreased compared to standard practice, irrespective of the device you use. It could be bispectral index or spectral entropy. And there's a similar finding that the consumption of sevoflurane is decreased by approximately 20%, indicating that most of our patients without neuromonitoring are sleeping too deep. And Dr. Whitlock, she ran a systematic review of the study by Seaver and added Chan, Radke, and her own data. And she found a odds ratio for the incidence of post-operative delirium of 0.6 when BIS monitoring or neuromonitoring is used during general anesthesia. However, so far, we don't know whether this is just an effect on delirium or whether there's also a very important effect on the mortality in this patients. And these questions were answered by a large study ran by Michael Eveden and the Engages Research Group, and they randomized more than 1,000 patients to receive neuromonitoring compared to not using neuromonitoring. And when looking at the supplementary data set, there's a clear survival advantage of patients who were having neuromonitoring in the group during general anesthesia compared to neuromonitoring compared to not using neuromonitoring and have usual care. So neuromonitoring helps you to decrease or to increase survival. And now we look at the outcome variable delirium. That was the primary outcome, and the overall incidence was, to our surprise, not difference between neuromonitoring guided anesthesia compared to usual care. And what is the reason for that? And there were some letters to the editor published in JAMA, and we wrote one of them. And the reasons for why there was probably no difference observed was in the diagnosis of delirium, in the screening methods, the fluctuation of delirium, and of course the group of Michael Eveden is very experienced with neuromonitoring, so they probably use lower anesthetic concentrations even when they are not using neuromonitoring, because they are familiar to go to the edge with their dosages of inhaled anesthetics and the opiates as well. So when looking at the most recent guidelines from the European Society of Anesthesiology and Intensive Care, they recommend for patients at risk for postoperative delirium to monitor anesthesia depth and to avoid too deep anesthesia. So this information is also found in the current guidelines, and this applies not only to total intravenous anesthesia, but also to general anesthesia with inhaled anesthetics as well. So when I summarize this section, the incidence of postoperative delirium can be decreased by the anesthesiologist, and this is a very important information. And you should use EEG neuromonitoring during general anesthesia whenever available. Avoid deep anesthesia, and there's several data I did not show that it's also advantages for anesthetics with favorable pharmacokinetics, and I always use desflurane and remifentanil in these patients. And when coming to the end of my lecture, I would like to present two case studies. One of them is a big patient scheduled for bariatric surgery, and we had to do surgery in the general ward bed because it was not possible to put him on a regular OR table. And this was a patient who was 40 years old, 285 kilograms, over a body size of 180 centimeters. And in this patient, we used a combined epidural and general anesthesia because we were not quite sure whether they need to convert to open surgery. And for induction, we went for thiopental, remifentanil, and rocuronium. And anesthesia was maintained with desflurane 4% end-tidal in combination with remifentanil. And the epidural catheter was used with ropivacaine 15 ml of 0.75%, and afterwards a continuous infusion of a lower concentration with the infusion rate of 10 ml per hour. There was a 150-minute duration of the procedure. The patient was extubated with skin closure, was transferred to general ward after post-anesthesia care unit, and returned home on the third post-operative day. And I have a final case study that was done in 2012, and this was a very easy case, but for me very emotional. There was a appendectomy that was scheduled by laparoscopy in a 14-year-old girl, 48 kilograms of body weight, 170 centimeters height. And my strategy was a general anesthesia with rapid sequence induction, and I used propofol, remifentanil, and suxamethonium, and anesthesia was maintained with 4% end-tidal desflurane and some remifentanil, and I gave some morphine, and we have very nice pediatric surgeons, and they took 20 minutes for the procedure. The patient was extubated with skin closure and returned home the same day, and it was very emotional for me because it was my daughter, and I can promise to you that I use desflurane anesthesia also in my very close relatives because I'm convinced of its beneficial effects. And so I would like to show you my last slide and summarizing that favorable pharmacokinetic properties of desflurane translate into rapid, precise, and safe awakening irrespective of body weight and duration of anesthesia. And desflurane is, to my experience and judgment, the almost ideal anesthetics. And as I said before, 95% of my anesthesia practice uses a combination of desflurane with any opioid. And I thank you very much for listening to me, and I will be very happy to answer your questions. Thank you very much.
Thank you very much, Professor Kienbaum, for this nice presentation with interesting and striking cases, I should say, especially the last case, the second case you have shared with us. Thank you very much. So we have some questions from our audiences, and I would like to remind our audiences, if they have any questions, please share with us through the chat function. And the first question is about the usage of desflurane in suspected case of malignant hyperthermia. What would you say about this question?
Okay. As any trigger substance, like any inhaled anesthetic, there's a clear contraindication in patients with suspected malignant hypothermia. So if there's any case, I recommend to go for a diagnosis of malignant hypothermia, but as long as you cannot exclude this in a suspected case, you are not allowed to use iso, sevoflurane, or desflurane, neither, and you also are not allowed to use suxamethonium, for example. So these are the classical trigger drugs, and there's no difference between sevoflurane and desflurane.
Thank you very much. And the other question, is there any update about the usage of desflurane in suspected cases? Sorry, this one was the previous question. What about the usage of inhaled anesthetic agents in scoliosis correction surgery? and suppression of SSEP and MEP?
Yeah. This is also a very good question because we know that inhaled anesthetics interfere with neuromonitoring, and many doctors prefer propofol-based anesthesia in these patients. To begin with, I I I very much like Suprane in back surgery because when patients are, excuse me, when patients are in the prone position and you have difficulties with doing BIS monitoring and they should not move and they should not stand up, you tend to overdose your anesthetics. And you don't know very well where you are with the propofol, but you have the end tidal concentration of the inhaled anesthetics. And yes, if we do MEPs, we try to avoid higher concentrations of desflurane. And I usually combine a lower dosage of desflurane, like zero point 0.4 mag, 0.5 mag, which is perfect with the SEPs and also with the MEPs. I give a opioid, and then I add some propofol, and as soon as neuromonitoring has been finished and the surgeon starts to close up the wound, I discontinue propofol, turn on, increase the dosage of desflurane, and then they wake up very nicely at the end of the procedure.
Uh, I would like to ask a question. Came to my mind with this question. Can you also make a comment about the uh, inhaled anesthetics and the intraoperative wake-up test, for example, during the spinal procedures?
Mhm. Okay, with
Would any would desflurane provide any benefit with that regard?
okay, with the neuromonitoring, we usually don't use the wake up tests anymore, but we use wake up surgery, for example, for brain tumors, brain tumor surgery, and there I have personal experiences, and we use Suprane in patients scheduled for awake brain tumor surgery, where we do local anesthesia of the bone in the scalp, and they have general anesthesia with remifentanil and Suprane to begin with, while opening the head. And once they are starting to do the surgery on the brain, we have some opiates left and turn off the Suprane, take off the endotracheal tube, and they are very, very nice and very awake and can follow commands. So we can use the wakefulness as the best neuromonitoring when doing surgery in very critical areas of the brain. But this
Okay.
should, of course, also work with scoliosis surgery. So wake up tests with scoliosis surgery. I don't have experience with that personally, but when translating this information from open brain surgery and awake brain surgery to scoliosis surgery and wake up tests, it should be very nice to do it in the same manner.
Okay. You have mentioned about the airway irritations. So this question is probably related with that. Are the supraglottic devices limiting the usage of desflurane? What about LMA usage with desflurane?
We use LMAs with desflurane, but we don't use mono desflurane anesthesia, what we combine with an opioid. So this is the airway irritation is a painful stimuli. And if you use opiates as a analgesic, this the reason is the chance to receive this stimulation is decreased. And every once in a while we see like kids with irritated airways to begin with, like chronic bronchitis, and scheduled for ENT surgery, and they have a acute inflammation of the trachea and the bronchi, and in these patients, I try to avoid desflurane, not taking any chance. But if there's no active inflammation, to my impression, we are perfectly fine and can use the advantages of the desflurane.
Okay. So the other question is the role of desflurane on hypoxic vasoconstriction response.
Yeah. So same matter as with the neuromonitoring, up to a concentration of 0.81%, there's no problem with hypoxic vasoconstriction. So when doing pulmonary surgery and eliminating one lung, we use suprane anesthesia because particularly these patients, I would like to have fully awake after extubation because they are prone to postoperative airway complications after pulmonary surgery. And this is the best patient group that benefit from suprane anesthesia because they are fully awake after surgery in order to decrease the risk of, for example, pneumonia after surgery. So this is a very good patient group to use suprane, and I'm not concerned about interference with hypoxic vasoconstriction. There's
So
only
maybe
one, there's only one issue. If the surgeon, if the surgeon hurts the visceral pleura, they smell the anesthetic, but this is an indicator for me that they did surgery at the wrong part of the lung. So so this is a proof of principle. So I like this for this reason as well.
okay. So continuing with the lung surgeries, does desflurane have a role in acute lung injury after lung resection? And or can we talk about any lung protective effects of desflurane?
Mhm. There's conflicting data with respect to lung protection. There's many studies, for example, from Beatrice Beck-Schimmer, showing that inhaled anesthetics provide lung protection in animal studies as well as in human surgery. And I'm convinced about this positive effect because it fits well in the line of organ protection. With respect to acute lung injury, um, I'm not aware of any data that reports an increased incidence of postoperative problems when patients were receiving desflurane. I think it's of course a mixed situation, but to my impression, it's very important that these patients are fully awake after after extubation, so that they have a good airway reflexes and they are not prone to silent aspiration. And I think this is the the, the effect that is more important compared to this theoretical idea that where there is, to my knowledge, no data available.
Maybe, I mean, not at the molecular level directly as a protective effect of desflurane on the lungs, but that early recovery of the reflexes and that water drinking test of Mackay that you have presented actually demonstrates a clear advantage from the safety perspective of additional or protection from the collateral maybe lung damages in the postoperative period. We can say that, I believe, right?
That's completely true. When I was starting to use desflurane 10, 15 years ago, every once in a while the surgeon told me, okay, the patient is coughing right after we extubated him. And they felt coughing could be not nice. But to my impression, coughing is an indicator of adequate airway reflexes. And if you were artificially ventilated for 1 to 3 hours, there's some secretion in the lungs. And of course, the best thing to do is to cough and get rid of it. So that was the first the first time we thought about airway reflexes and what is the meaning of coughing after extubation. And this is in line with the data by McKay, of course.
There are a couple of questions about inhaled anesthesia in pediatric patients. Is desflurane safe in pediatric patients? Is there any risk of bronchospasm? And what about the induction with inhalational agents in pediatric patients,
Okay.
and specifically with
Okay.
desflurane?
Okay, desflurane is not recommended for inhaled induction, doesn't work because half of the patients stop breathing. And for inhaled induction, you need the patient to be breathing. So this cannot be recommended, doesn't work. With respect to airway irritation, it's the same thing. If the airways do have a chronic inflammation, I'm a little bit cautious in these patients, and I avoid desflurane in these patients just because of theoretical concerns. But but I haven't seen any problems before with that. And yes, after inhaled induction with sevoflurane, I always switch to Suprane because I would like to have the beneficial effects during the recovery phase so that also pediatric patients wake up faster, more precise with recovered airways. And I don't have a line of argumentation that anything could be different compared to adult patients with respect to safety issues.
So maybe we can combine those two questions. The first one is, do you advise desflurane with oxygen and nitrous oxide mixture? And is desflurane safe in low flow anesthesia? And the rate of flow rate given in this question is 0.5 liter per minute with 100% oxygen.
To start with the last part of the question, yes. In contrast to SIVO, in the US, there's a recommendation in the SPC that sevoflurane anesthesia should not be used with fresh gas flows below 2 liters. And in contrast to that, desflurane anesthesia can be used with minimal flow. I most of the times use 0.5 or even less liters per minute of fresh gas flow in oxygen. And the first part of the question was
Oxygen and nitrous
and
oxide
nitrous
mixture.
oxide. Of course, nitrous oxide, as also demonstrated in the HMAC charts I showed. I didn't talk about the nitrous oxide, but this data was included there as well. The nitrous oxide decreases the MAC value by more than 50% when using nitrous oxide. And of course, I personally like nitrous oxide. There was some concern 20 years ago when there were data from a Australian group indicating that when you were using nitrous oxide, the cardiovascular problems increase during surgery. But Enigma was the trial name, Enigma trial. But they reanalyzed the Enigma data and they readjusted their conclusion. And in the long run, also the reanalyzed Enigma data clearly showed that there was no increase in cardiovascular events when using nitrous oxide, but it's favorable with respect to wake up times. And what the nitrous oxide does as well, it stabilizes the cardiovascular system because it works at a NMDA receptor antagonist that is locked to a norepinephrine transporter, and these transporters are inhibited, so norepinephrine concentration at the receptors slightly increases, like a endogenous norepinephrine administration, giving you a very stable cardiovascular situation. So for that reason, I can clearly recommend, but unfortunately for other reasons like pipes and supply and different things, we don't have it anymore. But if somebody says, okay, Peter, you can have nitrous oxide, do you want to take it? Then I say, yes, I really like to.
Would it be practical in the low flow anesthesia as well, in very low flow metabolic rate, for example? I
Mm.
mean, would it be practical
No, no, low flow.
mixing it?
You have to be careful with low flow because you need to administer at least the amount of oxygen that is used by the patient. So the patient
Yeah.
needs 2 to 300 mLs of oxygen per minute during anesthesia. And if you have like 50% nitrous oxide and a low flow of 500 ml, I would be a little bit concerned that the patient may get hypoxic. So it doesn't work with low flow anesthesia as low as zero point 0.5 ml.
Yeah. Okay. I think we can merge those two questions as well. When you say avoid deep plane of anesthesia, how deep are you referring to? What is considered to be deep? And can we extubate in desflurane deep plane anesthesia?
Mhm. Deep anesthesia is, for my impression, is a BIS value below 40, and also a obvious need for cardiovascular support. So with increasing dosages of all anesthetics, you decrease the blood pressure, and once you need a certain amount of norepinephrine or phenylephrine, this is an indicator of deep anesthesia combined with a low BIS value. And in these combinations, I try to titrate the anesthetic depth to BIS 45, 50, and the least amount of norepinephrine that is needed to achieve adequate cardiovascular situation. And can we extubate in deep desflurane anesthesia? Um, of course, you could. I mean, it's always a matter of breathing. If you use remifentanil, they usually don't breathe. So I usually when I start weaning from anesthesia, they have some morphine and I turn off the remifentanil and I let them breathe during while they are intubated, and then I at the end I turn off the desflurane. It takes 5 4 minutes until they can be extubated. Of course, you could also extubate them during deep desflurane anesthesia, no problem.
Okay. There was a question about the brain protection. What is the proposed mechanism for brain protection by inhaled anesthetics that was suggested by some studies in your presentation?
It is a observation, but the exact mechanism has not been identified. They are working on that, and this is very important because you need to understand the mechanism in order to understand the interference, like propofol. How does propofol interfere with organ protection? And we don't know yet because we don't know the exact mechanism. It has something to do with potassium ATP channels, for sure, but there's, I think, several mechanisms more than that probably have not been identified so far. So this is ongoing research in many groups.
Okay. Is isoflurane still preferred over desflurane for craniotomies?
No, no.
Short and clear. Thank you. At what level is desflurane causes sympathomimetic stimulation?
High concentrations that are administered with high fresh gas flows. And when you use the fresh gas flow, the number like 2, 4, 6, and the vaporizer number 2, 4, 5, inspiratory concentration, this product should not be higher than 24. So I use for after intubation, I use a fresh gas flow of 1 liter and an inspiratory concentration of 18 for 1 minute, and then I decrease to 5, 4 something. You could also start with 4 liters of fresh gas flow and an end tidal concentration of 6, or the other way around, that are below 24. And this is a matter of experience. When you give like fresh gas flow 10 and turn on the vaporizer all the way, and you don't have a baseline opioid analgesia, you take the chance of having a painful stimuli giving you sympathetic activation. But the mechanism is exactly the same compared to when you insert a laryngoscope for endotracheal intubation and your anesthesia doesn't have a sufficient depth. So this happens every once in a while. No anesthesiologist is concerned about that. Deep anesthesia, everything is fine. And this is the same mechanism with high concentrations of despair.
And here, as you have mentioned, that rule of 24 is probably a good safety check with that regard.
Yeah, I can recommend.
Okay,
I
I
have,
think,
I have another note to the question isoflurane for brain tumor surgery. I would
okay.
be concerned about wake up times. When patients receive isoflurane for brain surgery with sufficient depth of anesthesia, it takes half an hour, 1 hour until they are fully awake. And in these patients, there's always the risk of, of a bleeding situation at the surgical site. And once they are extubated, you want to have them really awake to identify bleeding or to see whether there's some seizure activity that is sometimes difficult to see when they are still sedated all the way. So that would be a major advantage. I know there was some discussion before about blood pressure and perfusion pressure and intracranial pressure, but the important thing in brain surgery is perfusion pressure. And you can achieve perfusion pressure during total intravenous anesthesia, during ketamine, during isoflurane, during desflurane, and this is no matter of the anesthetic. But the difference, to my impression, is with respect to wake up times and the possibility to perform a good neurological evaluation once the patient is in the post-anesthesia care unit. And that would be the line of argumentation in favor of desflurane.
There's a uh, final and very good question, and this question may give us a chance to very shortly summarize from the practical perspective the usage of desflurane. And the question is, shall we switch over to desflurane after inhalation induction with sevoflurane in pediatric cases? And also, how would you recommend the usage of desflurane in adult patients as well? I mean, can you just briefly describe the induction and transition to maintenance in both pediatrics and adult patients?
Okay, I use sevoflurane for inhaled induction in pediatric patients. Use 8% with a fresh gas flow of 8. And once they are intracheally intubated, I have a fresh gas flow of 4 in order to get rid of the SIVO and then switch to desflurane 5-6% inspiratory concentration and do the transition that way. If the procedure lasts only 5 or 10 minutes, there's no real reason to do that, because when remembering the decrement times of elimination, there's going to be a difference after 20, 30, 40 minutes. So if there's only 15 minutes anesthesia because of they will have a short look into the ear, for example, or just do some diagnostics, I just go for SIVO and don't change, and that'll be fine. But if the anesthesia is longer than half an hour, 45 minutes, I have the impression that there's a clear benefit with respect to precision of waking up when changing to desflurane. In the adult patients, I hardly use any sevoflurane at all. So there's the, we if we do inhaled induction, I do it the same way as in kids. But otherwise, I cannot think about a situation where I should go for the sevoflurane. But this is my personal attitude. To my impression, I like to perform my anesthesia always the same. Or do it always the same, have a standard technique, And in that case, you know if something is not the way it should be. Because if you do SIVO and ISO and DES and TIVA and change it all the time with and without nerve blocks and this and that, it's difficult to observe if something is not the way it's supposed to be, because you do have different heart rates all the time, you do have different blood pressures all the time, the patients react differently, it takes more or less until they wake up. But if you have one standard anesthesia that you know very, very well, it's very easy to find out if something is not the normal way. And I'm very sure that you gain a few minutes until you notice that something is not perfect. And I think our patients deserve a perfect treatment.
Absolutely. So the other question, will the use of dexmedetomidine
Mhm.
alongside desflurane combat some of the symptomatic effects?
I use, let's see, will the use in, okay. You don't need the DEX for the sympathomimetic effects. I recommend to use opioids. I mean, you treat painful stimuli with opioids and not with sympathetic blockers. But I do like dexmedetomidine for patients at risk for a postoperative delirium. And this is even better than clonidine. The affinity to different alpha 2 receptors differs between the two drugs. So it's not the same where it works in the brain. And of course, the pharmacokinetics are different as well. So if I do have a patient with a risk of postoperative delirium, I start with low dosages, zero point 0.2 micrograms per kilo an hour of dexmedetomidine, and every once in a while increase. For example, for fast track cardiac surgery, where we want to extubate patients in the OR, they receive dexmedetomidine um, during anesthesia, and we have very, very good results with respect to wake up and avoidance of delirium. Although the research data has conflicting results, there are studies that identify clear beneficial effects, and there are also studies that could not support this idea. But to my impression, in these patients, it's very good.
There is a futuristic question, I may say. Are we to expect an even better inhaled anesthetic in the future? And related with that, if you are given a chance to invent a new inhaled anesthetic in place of desflurane, what would be the additional characteristics that you would be willing to have?
With respect to pharmacokinetics, we have worked with xenon anesthesia, and xenon is even faster compared to desflurane. And xenon gives and desflurane and xenon gives you also a very good cardiovascular stability. The blood pressure increases instead of decrease because of the NMDA receptor antagonism, similar to nitrous oxide. But it's you need very high inspiratory concentrations, and this is difficult in many situations, irrespective of the price and the availability of the drug. But to my impression, the the combin the how do you say, the compromise between solubility and speed of recovery and the concentration you need to administer. If you have a lower solubility, a faster recovery, you need higher inspiratory concentrations. And then minimal flow anesthesia, for example, doesn't work anymore, because we talked about that before. So I think it's quite optimal if you can get rid of the airway pungency. It's nice, because if doctors are not aware of these mechanisms, there's not the chance that they try to get sympathetic activation. But as long as they are aware and educated, it doesn't really make a difference. So I think the Deslorraine is near perfect, and I've been thinking about these ideas for a long time, but I don't have a very good line of argumentation to go for a even better one. And as far as I know, there's nothing in the pipeline of the pharmaceutical industry, so there's no plans in bringing up new substances. I mean, the history is like 20, 30 years ago when Baxter was inventing the SIBO and the DES, and they were trying many halogenated carbohydrates, and there was a very clear and good selection. And I think I'm very satisfied with the Destroying.
Okay. And when we use propofol, remifentanil infusion, and desflurane, which one would you recommend to stop first and stop
Propofol,
last?
propofol,
Propofol
propofol to be
first.
stopped first, and remifentanil and Desflurane. This is a matter of personal experience. If you stop the remifentanil second, you need some sort of analgesia. So you either have a epidural catheter in place, or you give some morphine in order to have the baseline analgesia. And I have baseline analgesia with morphine and turn the remifentanil off, and and turn off the Desflurane at the end, because it's very reliable. When you use like 3 to 4 to 5 um, percent end-tidal Desflurane, it takes 5 minutes roundabout until patients wake up, and it's it's really surprisingly precise.
Great. I think we answered all the questions. And uh, before closing the session, uh, I may say from my perspective, the main takeaways probably would be that desflurane appears to be, as you have also mentioned in your last slide, and you have repeated while answering the question just before. This fluorine appears to be the almost perfect or the closest to perfect inhaled anesthetic at the moment, which you can even choose, prefer for yourself and your beloved ones. I mean, this is a very important message that I get from that webinar, that's lecture. Thank you very much, Professor Kimbaum. Would you have any last words before we close?
Yeah, thank you very much, Anil, for the moderation. It was a great pleasure to talk to you. It's a little bit sad that it's a virtual conference. I would have loved to see you in real and discuss with you in a real conference, and I really hope that there will be the chance and the opportunity in the near future that COVID activity decreases and we are able to have better traveling conditions. And I would really love to talk to you in real in a symposium, and I hope to be able to do so. And until that time, we have to do this virtual compromise, which is very nice. And I thank you, Anil, for the invitation and the moderation, and I thank the whole Baxter team for for choosing me as one of your lecturers. And I wish you all a very pleasant good evening, and I wish you all the best with the Suprane. And I can really encourage you, if you're not Suprane users, to give it a try and find someone who is very familiar and ask him to get started with a personal experience at your side. So thank you very much. Have a good evening, and see you soon again. Bye bye.
Thank you. Thank you very much, Professor Kimbaum. And I can only echo and repeat your good wishes about having face-to-face meetings, coming together again. I hope this will happen soon, and we would very much love to welcome you in our region, in our countries, and to have those face-to-face interactions with our uh, physicians, anesthesiologists. And I also would like to thank everyone participating this webinar. And now it is time to say good evening, good afternoon, and hope to meet you and see you face to face. Thank you very much.
Stay safe and healthy. Goodbye.
Yes, bye bye.